Okay, thank you all very much again, and thanks for staying behind for this hour to listen to this talk. I thought the previous two talks were really good. I've never heard a talk about myeloma bone disease that was delivered so nicely for lay people to understand. I thought the talk by our physiotherapist is particularly useful. I learned a lot of things from her. I was starting to calculate my heart rate and next time. And the sharing from Madam Mustiati too, I thought particularly, people who suffer from chronic diseases or severe illness, they can respond in different ways. But actually what comes true is a very positive outlook, actually even going through treatment, and then after that, with her acceptance of her diagnosis. I think that kind of attitude actually helped her in her journey as well. So I think these are very important things to take away. She did mention that she's actually a school principal. She runs the Montessori schools in Jakarta. And that's why she talked about working with children. I don't know whether it's the teacher and the principal and her that help her through this kind of thing, but certainly there's a very strong character. So today, to finish off, I think the last thing is, we've heard from previous doctors about how much advances that we've come over the years in terms of treatment for myeloma. Myeloma now can be considered in the majority of the patients to be somewhat of a chronic illness. Patients survive for quite a long time, longer number of years, and in time to come, this may become even longer. Okay, so we have patients surviving out to 8 years, 10 years, and even more. So when it comes to that, then I think our focus needs to be much broader now. We need to start to consider, are all patients with myeloma the same? And so that's where I start to talk, is are all myeloma the same? And clearly, if we have enough friends with myeloma, such as in this group, when we talk to each other, we realize that we are not all the same. Because there are some patients with the same stage of disease, for example, that have very different outcome, very different response to their treatment. We know, although we now say that patients live very long, we also know in very recent years that we may have some friends or other patients treated by the same doctors that may have died within 2 or 3 years, short time, right? So clearly, not all myeloma patients are the same. And I think if we continue to treat every single myeloma as the same, with exactly the same treatment, with exactly the same kind of strategy, then we may be doing different groups of myeloma patient disservice. Okay, and I'll explain what I mean by that. And this will give you some insights into, as a medical community, what are the next steps that we are trying to do to try to help every single subgroup of these myeloma patients to improve their outcome. So when we talk about starting to classify myeloma patients, one of the very well-known systems is the staging system, which Dr. Satish has already mentioned. It's based on 2 very simple blood tests, beta-2 microglobulin as well as albumin. All the hospitals can do these blood tests. In fact, your doctor would have done that when you were diagnosed in the first place. And they'll tell us whether they are stage 1, stage 2, stage 3. It doesn't tell us much about how many organs is affected and so on and so forth. But what it does is tell us how much myeloma there is. When you have more myeloma, it means that there's more extensive involvement and that these patients tend to maybe have not as good a response, or the disease may come back earlier, the outcome not as good as those with early stage disease where there is very little disease. So this is a very simple, well-validated, well-used staging system. But more recently, and you see that some of the patients who are diagnosed in the last 4 or 5 years, your doctors may do the bone marrow test and send your bone marrow cells for a genetic test. You may have doctors coming back to tell you that you've got bad risk genetics, your genetics is okay, is good, and so on. So these are the different genetics. The detail is not important, but suffice it to say, their frequency, how often they occur is very different. Some are quite common, some are not so common. And also, some of them are associated with poorer outcome, whereas others are better. Okay? So there are different types of genetics that tell us whether we have good disease or bad disease as well. Okay, and more recently, we have tried to put these 2 things together, the staging system and the genetic test, so that we can separate patients into 3 different groups with very different outcomes. So this curve here tells us about outcome. Okay, this is number of years with that myeloma. So you can see here that those good risk patients outcome is pretty good. Majority of them, about 50% are still alive at 10 years. Whereas those with bad risk disease, about 50% of them only live for about 3 years. Okay, so clearly there's a very different range, right? Whether we like it or not, that's the nature of the beast. So we shouldn't hide from this reality, but we should try to understand what this means. And we know that these so-called prognostic factors, things that we use to tell whether a patient has good disease or bad disease, are things like age, and previously I mentioned albumin, beta-2 microglobulin, and then the genetics. And these reflect different aspects of the individual as well as the disease. So things like age and albumin clearly tell you about the host, and it has impact because clearly if you're older, you cannot tolerate the treatment as well, you get more side effects. That may affect your treatment, and then that may affect your outcome, right? Whereas if you're a young patient, you can go to transplant, even very strong chemotherapy, very high doses of even the Velcade and so on. You may tolerate the neuropathy and the diarrhea and so on a bit better, and tolerate the treatment better, so you get more optimal treatment. There are other things that reflect the amount of disease, and then other things that reflect the biology of the disease. Then very often, after we treat the patient, even if they have so-called a good risk disease, they receive the treatment, but they have not very good response. We have seen these patients before. Do we still say that, don't worry, you have good risk disease, just carry on as per usual, you should be fine? Actually not true, because if the patients are quite resistant to the treatment, it tells us there's something else about this myeloma that we are not picking up with all these standard tests. Okay, that tells us that we need to then treat this patient as a high-risk disease. We need to re-counsel the patient, modify the expectation, tell them that, okay, this means that we're going to change our treatment strategy, we'll work together to try to optimize it, but the result and outcome may not be exactly the same as what we did before. So, these are the different factors. And because in the past, people say that myeloma is incurable, so we just give everyone the best treatment that we have. Okay, we give them the Velcade treatment up front, transplant them, give them maintenance treatment with Revlimid, all these very expensive, very potent, very good treatment. And that's because we think that they're not curable. But actually more recently, with myeloma patients surviving longer now, different groups around the world are interested to see, can we identify myeloma patients that actually survive a long time? And in fact, I was speaking to some of the members of the audience. There are a number of you here that have survived with myeloma for more than 10 years. And even some of you that are surviving with myeloma for more than 10 years after receiving not too much treatment, quite old-fashioned type treatment, because if you had myeloma 10 years ago, you would be treated with just VAD, transplant, and then you are living, maybe with some relapse, but treated again, responded well, and then no disease, relapse again, but surviving more than 10 years. So what are these factors that people can find? So here, look at this curve here, right? 10 years with myeloma. These guys over here have more than 75% chance of surviving more than 10 years. That means more than half of these patients here survive for more than 10 years. And what are these factors that can identify these patients? If they're younger than 55, if they do not have ISS stage 3 disease, and if they do not have the poor risk genetics. So if you have ISS stage 1 and 2, no high risk genetics, you're young, in fact, on fairly old-fashioned treatment, you have a good chance of long survival. So now this means that we have to think about our strategy again. Is it really beneficial to give everyone all our best weapons up front and deprive them of good treatment subsequently when they relapse? And at the same time, charging, asking them to pay all the cost of this expensive treatment? Or can we give them less intensive type of treatment and then keeping the really potent treatment later. So these are things that we as clinicians will have to start to address some of these issues that will eventually bring benefit to the patient, because we want to give the patient good care that will improve their outcome, but we also want to give them good value of care that is appropriate. It doesn't mean the best treatment, the most expensive treatment is beneficial for every single one. So that's an important thing for us as physicians to remember, and that's where we are going. So the question is, should we treat every myeloma the same? I would say that at the moment, we have learned something from the recent clinical trials, that certain subgroup of patients with certain genetics definitely benefit from the use of certain treatment. So if you have 414 translocation myeloma, they benefit from Velcade, and they may even benefit from Velcade in the maintenance setting. Recently, there is some data that suggests the use of 2 transplant may be more beneficial for these group of patients than a single transplant. Okay, certain the Revlimid maintenance are more useful for the not very high-risk patients, and high-risk patients still the data is not clear. And thalidomide, which is still used for maintenance for a number of patients, in fact is harmful for patients with 17p13 deletion. Okay, so it doesn't always mean that more treatment is better. There are some treatment that in fact may turn out to be harmful in certain settings for certain subgroups of patients. So it is important for us to discuss this matter in an open manner with the patient, and for us as medical physicians to actually be abreast and continue to ask ourselves these questions to find better solutions for the patients. So if I were to summarize that risk stratification, in terms of the genetics risk here, we can separate patients into 4 slightly different categories. The very good risk patient, as I mentioned before, with a good chance of surviving for more than 10 years. This constitutes about 20% of the patient. The majority of patients that have benefited from the advances in treatment in recent years, with the Velcade use up front and so on, are in the so-called standard risk, as well as this particular group of patients with the 414 translocation. They are the majority of the patients. The survival here is now about 7 to 8 years. For this group of patients, it's 5 years and pushing upwards as well. Compared to the old days, where this group of patients is only surviving for about 2 years, this is major advance. But we still have a rarer group of patients with this very bad 17p deletion that, despite all the current treatments, are still not doing well. Okay, so this is the group of patients that we really need to find better, newer treatment for. Now, I would also hasten to add that this refers to the median, the average. If you have 100 patients, 50 patients will die within 2 years. But there is another 50 patients that survive longer. Okay, so that doesn't mean that, if I have this disease, if my clock ticks to 2 years, that means I'm getting ready to lie down. That's not the message here. As a patient, as a treating physician, we always work together to try to give you the best treatment in the appropriate circumstances to prolong your life. But it is always good to have some framework, especially for us, to try to improve the outcome, so that we have something to compare. If 3 years later I give you the same talk and I say that, hey, for this group of patients, we're now surviving for 5 years. Now that we know is advanced, right? Without this kind of framework, we really don't know whether we're making any improvement or not. So what do I think going forward is an important thing for us to do for these different group of patients? For the very good risk of patient, I'm seriously, we are considering that we may not need to give them maintenance treatment. These patients have very indolent cause of disease. Their disease may come back. That's not what I'm saying, that the disease will not come back. But they come back and they're easily treatable again when they come back. Okay, so by giving them this maintenance, we're just window dressing in a sense, giving them a sense of security, making the physician feel good that we're doing something for the patient. But actually it may not be benefiting the patient, and they are having the added inconvenience of having to take the pill, suffering some side effects, and as well at the same time, not having any benefit. So, but these things need to be addressed properly in clinical trial, and this is something that in Asia, now that we have a group of physicians that work together on myeloma disease, that we can start to derive or design clinical trials to ask this question. For the standard risk patient, which is where most of the current improvement in treatment have benefited, I think the important thing here is we want to further optimize the treatment. Can we reduce the side effects of the patient? For example, giving them the treatment, for example, Velcade on a weekly basis, giving them the treatment through subcutaneous means so that they do not get the neuropathy that other patients get. Improving the quality and the value of the treatment, such as providing outpatient transplant, where the patients can stay at home in the comfort of their own home while receiving the treatment. And that reduces hospitalization time, cost to the patient, and so on. If we are talking about Velcade as maintenance therapy, being a subcutaneous injection, over at NUHS, we are starting to consider sending the nurses, our nightingales, to the patient's home to inject the subcutaneous vaccine, so that the patient don't need to come to hospital every month, a few times just for the injection. Less restriction on their mobility and their ability to work, don't need to take so much time off from work to go to hospital and so on. So we're looking at ways to make their life even better, okay, now that the treatment has improved their outcome. For the intermediate, these are the 414 translocation. We are looking at going back potentially to 2 autologous transplants because the data from recent studies provide a strong justification and suggestion of that. And then for the high-risk patient, the 17P really, we have to do the best that we currently have, and we have to avoid some of the things that are harmful for these patients, like thalidomide and maintenance and so on. But really, these are the groups that really, the new clinical trials and new ways of thinking of treating myeloma patients should come in. You know, just by giving them a bit more, you know, different types of novel agents and going the same old ways, I don't think is a way to go for them in the future. We need to look at completely different strategies, using antibodies, using immune therapy, allogeneic transplant, cellular therapy. You know, these are new types of treatment on the horizon, completely different from what we're using now. Using novel combinations of drugs that target a different pathway, or trying specifically to understand why these patients do so badly. What is wrong with a patient having 17P in the cell? What makes these cells so drug resistant? To try to target the root cause. So this is where the research and new therapeutic strategy and clinical trials would be the way to go for these patients in the future. Okay, so I think that is probably my last slide. You know, just trying to highlight to you some of the efforts that the medical community is still going forward with. We're not happy enough just to say that we have improved the outcome of these patients. We want to look specifically at different subgroups, whether we can continue to improve either their quality of life, their treatment further, and that will keep people like us busy, you know, and coming up with better treatment for you. And hopefully in a few years' time, when we show these kind of graph again, we'll continue to see that the survival curve is improving for our patients. That's my, thank you all very much.